Welcome to ATCM, the emergency medicine channel. Shall I start?
Yeah.
A 68-year-old male patient presented with complaints of fever with loose stools and abdominal pain for the past 2-3 days. On initial 10-second assessment, airways patent, no gurgling of sounds, no secretions, and breathing respiratory rate is 20 per minute with saturation of 99% in room air.
Okay.
Air entry is bilaterally equal. Circulation, pulse rate is 104 per minute with BP of 160, and CRT is less than 3 seconds.
Okay.
And
So patient here is at tachycardia.
Tachycardia with BP is 160.
BP on the lower side. So what may be the cause for the same?
Patient has multiple episodes of loose stools, so more possibly dehydration is the cause for it.
Okay. So dehydration.
Yeah,
So how do you assess for dehydration?
we can check for the pulse rate, BP, and also we can check for the capillary refill time, and
Capillary
also we can check for the IVC, skin turgor, tongue, mucosa, and CRT, capillary refill time. We can check for the IVC,
Dryness of tongue. So these are the in the initial stage we can also check for how we can ask the patient how was his urine output and whether output was there or not. Okay. And later on, how do we classify? Do you know how to classify dehydration?
Mild, moderate, and severe dehydration is there.
Okay. So in the mild state, we will have the skin turgor or like a dryness of tongue, and in mild moderate cases, we will have the sunken eyes, and later on in the severe dehydration, we will have comatose patient or patient with decreased sensorium and able to drink fluids. Okay. Okay. Continue.
And in disability, GCS is 15 by 15 with people bilaterally equal and reactive. Exposure wise, temperature is 101.5. So initially we put the IV cannula and depending upon the fluid status of the patient, started on IV fluids, and also injection paracetamol 1 gram IV stat was given.
Okay.
And coming into the ample history,
what were the adjuncts? Any adjuncts? Do you need any adjuncts here?
Yes,
actually?
adjuncts we done CBC CRP, point of care. Total count is 17,000 with HB 12.8 and platelet 3 lakh with CRP of 62.
CRP 62. Total count of?
17,000.
17,000. Okay. And
in BBG, the pH is 7.3 with bicarb of 16 and PCO2 of 31 and lactate is 2.8 and sodium is 128 and potassium is 3.1.
So can you explain the blood gas right now?
pH is slightly lower side with bicarb is also less and PCO2 is 31. So metabolic acidosis picture is there with sodium 128 and potassium is 3.1.
3.1.
Both are in lower side.
Okay. So when what can be attributed to this metabolic acidosis?
Because of the loss of the bicarbonate through the stools, there will be metabolic acidosis and sodium and potassium. Electrolyte abnormalities are also there.
Okay.
But patient is fully conscious and oriented, so we send worker for the sodium and also potassium 3.1. We wait for the labs and labs also came out to be between 3 and 3.5.
Okay. What are the blood gas changes that you can get in acute gastroenteritis?
Hyperchloremic metabolic acidosis picture can be there and hyponatremia and hypokalemia. And if there is severe dehydration and all, hyperlactemia and also.
Okay. And in vomiting, how will be the blood gas?
Metabolic alkalosis will be because of the loss of the H plus.
Yeah. Potassium will be potassium will be on the lower side. Okay.
And coming into the ample history, patient is not allergic to any medications, non-case of diabetes and hypertension, and patient 68-year-old male patient hospitalized for 3 weeks ago for pneumonia and treated with broad-spectrum antibiotics, presented to our ER with complaints of fever and frequent watery stools which are foul smelling and non-bloody associated with abdominal cramps that was developed 3 days back. There is no history of vomiting, no history of blood in stools, no history of recent travel or consumption of food from outside.
Okay.
And
so your diagnosis as such here is?
There is a history of recent antibiotic use in the patient.
Okay.
And so we put a provisional diagnosis of maybe more possibly any Clostridium difficile. We put it in an differential diagnosis, and also in case of elderly we have to rule out malignancy and all. And also acute infective causes has to be ruled out.
Okay. There was no blood in stools, right?
Blood in stools is not there.
Okay. So this patient is having abdominal pain is there, and
Abdominal pain associated with fever and loose stools.
okay. How can you differentiate between a diarrhea which is like involving in small intestine whereas large intestine?
If it is small intestine, there will be larger volume will be there. If it is large intestine, small volume will be there.
Other than that, abdominal pain will be more towards in the large intestine diarrhea, whereas it will be less pain or severe pain will not be seen in case of small intestinal diarrhea. So how do you like define diarrhea? How many stools that? Can you explain?
Acute diarrhea is a sudden onset of an increase in the normal water content of the stool, that is 10 ml per kg per day of fluid in stool. It is 3 to 4 times to more than 20 bowel movements in a 24-hour period. It is defined as a frequency of defecation more than 3 bowel movements per day for a daily stool weight more than 250 grams. And the mechanisms mainly involved, if there is increased intestinal secretion or decreased intestinal absorption or increased osmotic load or abnormal intestinal mobility. So basically the fluid absorption is mainly by the two mechanisms, that is passively with the transport of sodium and is actively with absorption of glucose. So in case of according to normal physiology, that at cellular level the intestinal absorption occurs through the villi and secretions through the crypti. But in case of this enterotoxin block and all, there will be passive sodium reabsorption will get blocked, so that there will be specifically stimulate the sodium excretion along with water. That much fluid loss will be there. But glucose dependent mechanism is not affected. So that is why we are giving ORS based treatment. And in case of diarrheal states and enterotoxins and inflammation, ischemia and all, this villi get disrupted with less involvement of crypts. So that there will be diminished intestinal villi absorption, but unopposed crypt secretion will be there. That will lead to the fluid loss.
Okay.
And also in case of increased intestinal mobility, that is in case of inflammatory bowel disease, neuropathies or shortened intestine secondary to surgery, that is the mechanism. And in case of antibiotic or nosocomial diarrhea like that, Clostridium difficile possibility is there. And in case
Clostridium, how do you like, is every antibiotic induced diarrhea Clostridium difficile diarrhea, or how to differentiate? How do you find out whether it's Clostridium difficile induced diarrhea?
if the risk factors are present, like
Okay, that doesn't mean that is a Clostridium difficile diarrhea, no? What are the investigations that you have to send for finding out whether it's Clostridium difficile is involved in or not?
we can do specifically stool assays can be done. Cytotoxicity, that is gold standard for 48 hours we will get the result. Or organism is best identified by the stool culture. And also other techniques like ELISA, latex agglutination test and all that.
Okay.
And we can do colonoscopy in colonoscopy we can see the pseudomembrane, that is yellowish plaques within the intestinal lumen and through the entire alimentary tract, typically limited to the right colon can be seen.
Okay. So other than that, if you give antibiotics also, patient can come with anaphylaxis also with the same symptoms. Patient can have gastroenteritis and that will be the symptom of the anaphylaxis. That will be different from this one. Okay. Further, what did we do?
In that case, we initially in this patients we initially stop the offending antibiotic in case of that, and we resuscitate with IV fluids and we start on potassium correction, and also we advise them to correct the nutrition also to the patient. And start
how much
on
was the potassium?
antibiotics.
Lab potassium was?
Lab potassium is 3.2.
3.2. Any ECG changes were noted?
ECG changes are not
No,
normal
not
signs.
okay. Okay. Potassium correction was IV correction was given.
We give the IV correction since the patient.
Such if there is no ECG changes, we can wait in initial cases. But as the patient has sick and gastritis was there, we cannot give oral correction, and because of that we gave IV correction, right? Okay.
And we also done the stool test and colonoscopy was also done, and we initiated on the oral vancomycin.
Okay. Which was the preferred fluid we give here?
We give ringer lactate, isotonic fluid.
Okay. Why do you prefer a ringer lactate or isotonic fluid over NS here?
It will again increase the metabolic acids.
It is more physiological. Okay. And more potassium will be, if at all we are giving RL, potassium will be on the more side. Okay. Okay. Go on.
And Basically, the Clostridium difficile is a spore-forming obligate anaerobic bacillus. It will lead to mild diarrhea to severe pseudomembranous colitis. So there will be two types of toxins will be there, toxin A and toxin B. Toxin A is an enterotoxin and toxin B is a cytotoxin. And there is also a third binary toxin which is more virulent, and it leads into neonatal pseudomembranous enterocolitis or post-operative pseudomembranous enterocolitis or antibiotic associated enterocolitis. So risk factors will be recent antibiotic use, GA surgery or any manipulation, or severe underlying medical illness, chemotherapy, gastric acid suppression with protein pump inhibitors or H2 blockers, and advancing age. And there is also chance for transmission of organism by direct human contact or as well as contact with the inanimate objects. And in that case, the pathophysiology is basically the linear relationship between the length of the hospital stay and the colonization of this Clostridium difficile and development of diarrhea. So in case antibiotic, the risk factors for will be the antibiotic plus chemotherapeutic agents and also proton pump inhibitors, antiviral agents and all. And if there is any history of bowel ischemia or inflammatory bowel disease. So if we give probiotics along with the antibiotics, that will reduce the incidence of Clostridium difficile. And the clinical features begins usually between 7 to 10 days after the institution of the antibiotic therapy. Can lead up to 60 days after antibiotic is discontinued. And may it lead to 3% chance for toxic megacolon and colonic perforation. At that time, we can have to involve the surgeons also.
Okay. What is the treatment for the same Clostridium difficile diarrhea? How do we treat?
The treatment is like discontinue the offending antibiotic, and we have to start on the
first one is discontinuing the offending antibiotic, and later on we have to supplement the ongoing loss, dietary need and maintenance dose of fluid should be given, and third one will be to start on antibiotics, right? Okay.
If the patient is a symptomatic carrier, no need for treatment, but if it is an initial episode, we can discontinue the antibiotic, and if it is mild, then the WBC will be less than 15,000. We can start on vancomycin, that is of 125 mg 4 times a day for 10 days. If it is moderate, that is WBC is more than 15,000 and patient is able to tolerate per orally, we can start on fidaxomicin 200 mg BD for 10 days.
And if you are not having a vancomycin or fidaxomicin, we can give metronidazole also. Okay. And if at all a patient is having recurrent Clostridium difficile diarrhea, how will you manage? What will be the treatment?
If it is a first relapse, we can give fidaxomicin 200 mg BD for 10 days if vancomycin was used for the initial episode. And we can also, otherwise we can try for tapered or pulsed vancomycin regimen. If standard regimen is used for the initial episode, that is 125 milligram of vancomycin can be used for 4 times per day for 10 to 14 days. Then it tapered down to 2 times per day for a week, and then once per day for a week, and then every 2 or 3 days for 2 to 8 weeks. That is in the case of the first relapse. If it is second relapse, similarly we can give this tapered or pulsed vancomycin, or we can give vancomycin 125 milligram 4 times per day per oral for 10 days, followed by rifaximin 100 mg TRD for 20 days.
And any newer trials that we have done which is being currently used? It's regarding like can transfer, I don't know, remember the name of the same?
Microbiota transfer.
Microbiota transfer of stool. Yeah. Okay. Anything else you want to say?
Which are the investigations we usually do is that we can do all the blood routines along with renal function tests and serum electrolytes. If we are suspecting any drug intoxication and all, we can there is possibility of theophylline, lithium or heavy metal intoxication. We can send for the drug levels. And if there is any past history of abdominal surgery, there is possibility for partial intestinal obstruction. So we have to do the abdominal X-ray. And if there is existence of diarrhea plus cough, we have to rule out any pneumonia, Legionella pneumonia and all. We have to take the chest X-ray. And there is another differential diagnosis is mesenteric ischemia. In that case, we can look for serum lactate level, CECT abdomen, and also mesenteric angiography.
Okay. So, does every patient coming to ER need IV fluids?
If he's orally tolerable to take, we can give oral fluids.
Okay, oral fluids, ORS.
ORS can be given.
So, what are the contents of ORS?
Sodium chloride, dextrose, potassium chloride, and trisodium citrate.
Sodium citrate is also there. Okay. Do you know how much of each is there?
Sodium chloride is 2.6 gram per liter. Potassium chloride is 1.5 gram per liter and trisodium citrate is 2.9 gram per liter.
Okay.
Dextrose is 13.5 gram per liter.
Anything else you want to say?
For infection control, we advise them with hand hygiene with the soap and water, since the spores are not killed by the alcohol-based drugs. And also in case of toxic megacolon and perforation, surgical referral.
Okay. Main thing is in this condition you have to stop the offending antibiotic and followed by fluid rehydration and antibiotics. Okay. Anything else? Nothing. No? Okay. Thank you.